Kia ora everyone and welcome to our Goodfellow webinar on strategies for identifying and managing atrial fibrillation. My name is Dr. Grace Lee and tonight I have the pleasure of talking to Dr. Andrew Martin, who is a cardiologist and electrophysiologist at Auckland DHB and the Auckland Heart Group. This webinar tonight is kindly supported by the Heart Foundation. I'd like to hand over to you now, Andrew.
Thank you very much, and thank you all for joining in, and thank you to Grace and the Goodfellow Unit for inviting me and having me this evening. So I'm hoping to talk this evening about atrial fibrillation, mainly from the perspective of awareness, detection and protection. First of all, when we talk about awareness, we need to recognise atrial fibrillation as a acquired heart rhythm condition. It's the most common arrhythmia that human beings develop. And it increases with frequency as we get older. It's independently associated with a risk of stroke and also heart failure and death. And these conditions, including heart failure, the prognosis for this is made worse by the presence of atrial fibrillation. The risk of dying from stroke can largely be mitigated by the use of oral anticoagulation, but all-cause mortality and death from complications like heart failure remain high despite guideline-adherent therapy. Approximately 10 to 30% of patients with atrial fibrillation are admitted to hospital each year, and they have cardiovascular, non-cardiovascular causes associated with this, meaning that those people with atrial fibrillation will have other comorbidities. This includes heart failure, stroke, as I mentioned, but also myocardial infarction, and hypertension, diabetes, sleep apnea. There's a number of associated metabolic conditions with atrial fibrillation. The current estimate for prevalence of this condition in developed countries ranges between 2 and 4%, perhaps as high as 5% in populations with more longevity. The true prevalence is underestimated as subclinical atrial fibrillation is quite frequent. We're understanding more about subclinical atrial fibrillation in our patients that have implanted monitoring devices such as pacemakers. We're understanding that a large number of persons with pacemakers will also have atrial fibrillation but be asymptomatic. This potentially is a risk for stroke that is as yet undetected and unidentified. In the New Zealand setting, stepping away from international data, we understand that atrial fibrillation is common. We all see this as part of our practice. But a large registry from general practice identified a prevalence of approximately 2% within general practice. What was interesting was, despite Maori New Zealanders living shorter lives than New Zealand Pākehā, the prevalence of atrial fibrillation is nearly twice as high in Maori New Zealanders compared with non-Maori. So we're aiming in conjunction with the Heart Foundation to increase public awareness. So this month is World Atrial Fibrillation Awareness Month, and the Heart Foundation are running an Atrial Fibrillation Awareness Week coming up. We're aiming to increase public awareness of the condition, its association with stroke, and the use of pulse checks. As part of this, we also consider the use of novel technology and how that might play a role in detection and diagnosis. And the rationale for undertaking this is, again, because of the risk of stroke. We know that atrial fibrillation is associated with stroke, and approximately 10% of all ischemic stroke is caused by atrial fibrillation. We also know that those patients with atrial fibrillation who have stroke tend to have a worse prognosis following their stroke, tend to have more morbidity and more disability as a consequence of that than other causes of ischemic stroke. There's evidence that community practice in patients over 65 that asymptomatic atrial fibrillation is common, and that single point of screen ECGs can detect this, but maybe there are ways that we can do this better, and maybe there are ways that our patients are doing this better and even informing us. I'd like to touch on that. Screening using handheld patient-activated ECG devices, when undertaken frequently, particularly in older age groups, does increase the yield of diagnosing atrial fibrillation, and perhaps these devices may play a role in the future. This is an emerging topic. Most of those found with atrial fibrillation by screening also have the same stroke risk or elevated stroke risk as those who are found via conventional methods. So the presence of symptoms or absence of symptoms doesn't seem to be an independent risk factor for stroke. meaning that those people with a high CHADS-VAS score or other scores associated that link and can predict stroke risk can be useful in this population of asymptomatic patients. So when we consider detection, the traditional triangle is that of palpitations, dyspnea and lightheadedness. We understand that those patients presenting to our practice with palpitations, that one of the differential diagnoses can include atrial fibrillation. For those that describe irregular palpitations, particularly if they have other vascular risk factors such as diabetes, hypertension, this is a differential diagnosis that we should consider. We understand this and know this. Dyspnea is a common presenting symptom for atrial fibrillation, particularly in our older patients. These patients often have fewer symptoms of palpitations, and perhaps effort limitation, maybe as a consequence of elevated ventricular rates, could be the cause of their dyspnea. Lightheadedness is also a common symptom associated with atrial fibrillation. Syncope, less common, but lightheadedness at the time of onset or offset, so those with more paroxysmal episodes. And as I mentioned before, there's a number of patients who are asymptomatic, and we don't have a good understanding of what the true prevalence of asymptomatic atrial fibrillation is, but we understand it to be increasing. We understand it to be high, rather than increasing. And so this is where we really talk about pulse checks. And pulse checks and teaching our patients, particularly those at higher risk, so that might be older patients, say over 65, 70, with hypertension, diabetes, or just anybody of older age groups, can be taught to check their pulse and evaluate for whether it's regular or irregular. Irregular pulse, the differential diagnosis would be atrial fibrillation or atrial ectopics or ventricular ectopics. Those who report irregular pulses can subsequently have an ECG and either be diagnosed with one of those conditions or potentially be evaluated with more prolonged monitoring to try and identify what the cause of their irregular pulse was. It's an important adjunct to the awareness and the diagnosis of atrial fibrillation. But the cornerstone to diagnosing atrial fibrillation is the electrocardiogram. This has been the tried and tested method now for decades. This example here shows clear-cut, irregularly spaced QRS complexes, no obvious atrial activity. And this remains the gold standard for diagnosing atrial fibrillation. More and more we're seeing in our practice, or I'm seeing in my practice, and you might be in yours, patients coming with monitors that they've purchased from the internet. The AliveCore is a useful monitor. This has been approved by the FDA for heart rhythm monitoring. It's been formally tested in a clinical trial and demonstrated to be as useful as event monitoring, also known as transtelephonic monitoring. In this situation, a patient has one of these pads, which is approximately 3 by 7 centimeters, that attaches, or that connects to their smart device via Bluetooth, and a single lead ECG can be obtained. One places fingertips on one pad, fingertips of left hand on one pad, and fingertips of right hand on the right hand pad. This generates a lead 1 ECG, and in general terms, the fidelity is very high. Those patients with lots of moisturizing in their fingertips often have less good contact, and those with movement disorders like Parkinson's will often have significant motion artifact, and those can make interpretation challenging. But this creates a 30-second snapshot of the ECG in one lead at that moment in time that the patient then has ownership for and can share with their healthcare provider via email, prints to a PDF which they can then email through. And this is something that patients can purchase on the internet in New Zealand and overseas. So you may have some patients with this, or it may even be something that you consider recommending to them as a way of monitoring and evaluating without necessarily needing more prolonged ECG type monitoring. The Apple Watch is an emerging technology. Apple Watch has been a piece of smart technology that's been an adjunct to the ecology of Apple for this past several years. So the ecosystem that goes with this includes the Apple Watch and a smart device, typically an iPhone, but can also be a computer. A background app that's not yet available outside of North America monitors the ECG. and it monitors an ECG in a similar way to what the AliveCore does by using the back of the Apple Watch as an electrode. This actually records ECGs continuously and can be sent and stored to healthcare practitioners. In North America, the Apple Watch study was presented at the American College of Cardiology meeting earlier this year, and it was compared with diagnosis of atrial fibrillation to Medicare data in patients over 65. Correlation was very good, more than 95%. The challenge was over-interpretation, so movement artifact and ectopic beats does tend to overestimate atrial fibrillation and can be one of the challenges. But again, a number of our patients will be owning Apple Watches. It's estimated that Apple will release this app technology to the rest of the world at some point in the new year. And so patients may well come to you with what they believe to be a diagnosis even before they've had a conventional 12-lead ECG, and understanding that and working through that is important. So if we switch topic to talking about protection, the main aim for protection with atrial fibrillation is to prevent stroke. Symptomatic management is also an important aspect, but I'll spend some time talking about stroke management. The key aspect to understanding stroke risk is to understand your patient's vascular risk profile. We know from published data that the presence of intermittent or persistent atrial fibrillation doesn't in its own right predict risk for stroke, but the presence or absence of other vascular risk factors does, meaning that two patients who are twins with identical vascular risk factors, one who has permanent atrial fibrillation, one who has an episode every year or two, has the same overall risk of stroke. Based on data originally gained in the UK and published by Greg Lipp and his group from Birmingham, teased out these risk markers further. We understand that there are important vascular risk markers for stroke in general terms, and these seem to be additionally useful at predicting stroke for patients with atrial fibrillation. This has led to the acronym CHADS-VASc risk score, which is the most commonly used risk score in Australasia and in Europe. This scoring system has a number of conditions, as you can see on the left-hand side of the screen, each of which is denoted with a score. We can then add up a score for an individual patient, and in general terms, scores of 1, 2, 3, and 4 are associated with a percent risk of stroke. So a CHADS-VASc score of 2 has an approximately 2% annual risk of stroke. A score of 4, approximately 4% annual risk of stroke. And so that's a useful way of predicting which patients may be at higher risk for stroke, and therefore those who are most interested in using anticoagulation as treatment for this. Now, when we decide and make choices about anticoagulation, one of the first things we need to consider is the presence or absence of a mechanical heart valve. In this situation, it's clear that atrial fibrillation in a mechanical heart valve patient should be treated with warfarin. Almost all of the time you will understand that and know that in terms of your patient's past medical history. Ordinarily, however, we don't, at the time of initial diagnosis, understand whether a patient might have moderate or severe mitral stenosis. They may have risk markers for that, but they may never have had an echo. For that group of patients, I tend to then still use the CHADS-VASc score, and if the CHADS-VASc score is 2 or higher, ordinarily would start a novel oral anticoagulant such as dabigatran or rivaroxaban. I then undertake echocardiography, and at that point in time, if I identify the presence or absence of severe mitral stenosis, would change tack and go on to warfarin as a vitamin K antagonist. In my practice, I don't see a particular reason for delaying starting an anticoagulant for a patient at high vascular risk. The reason that warfarin is preferred in the presence of moderate or severe mitral stenosis isn't for any mechanistic or pharmacological reason. It's really based on the clinical trials, which happen to exclude these patients. And there's no biological reason why these agents wouldn't work. It just so happens that they were excluded from trials. So again, in my practice, if somebody's at high risk, I will start an anticoagulant, organise an echo, and then potentially change tack afterwards if need be. It's important to note that aspirin no longer has a role in guidelines for stroke risk reduction. What we know about aspirin is that it does reduce stroke a little bit, but we know from BAFTA trial in the UK from Birmingham, again Greg Lip's work in the mid-2000s, that warfarin is a significantly superior agent to reducing stroke for those patients with atrial fibrillation. And in that particular publication, there was no difference in major bleeding between warfarin and aspirin, leading to the initial recommendation that warfarin is the preferred agent for those patients at higher stroke risk. Moving on to more contemporary data, aspirin was trialled against apixaban, one of the other non-vitamin K oral anti-antagonists that we don't have available routinely in New Zealand, and that again showed the same story. Aspirin has a lower prevention rate, or I should say apixaban reduces the risk of stroke better than aspirin, but the overall risk of bleeding is the same between these two. So really in my practice, if a patient is at higher CHA2DS2-VASc score greater than 0, I'm thinking about novel oral anticoagulants such as dabigatran or rivaroxaban. One should note that female gender as its own sole risk factor probably doesn't meet the bar if that's the only risk factor for recommending a novel oral agent. If you have a female patient with type 2 diabetes, that scores 2 points and would be a reasonable patient to start an oral anticoagulant. Similarly, if you have a male patient with diabetes, it would be a reasonable thing to consider, particularly if their bleeding risk profile is low. So opportunities to protect from atrial fibrillation related stroke is really to ensure that patients who are at risk are appropriately anticoagulated and that their other vascular risk factors are assessed and managed as well as possible. We'll go into that in a little bit more detail later. It's appropriate to review those patients on antiplatelet therapy and not use aspirin or clopidogrel as monotherapy for stroke prevention. There are some patients who have a combination of atrial fibrillation and vascular disease, perhaps having had myocardial infarction and PCI procedures, who require a truncated course of antiplatelet therapy in addition to their oral anticoagulant, but current guideline data doesn't support the use of aspirin and clopidogrel long-term in patients who have coronary stent work and atrial fibrillation. We tend to continue antiplatelet therapy in these patients for between 1 and 3 months, perhaps as long as 6 months, depending on what the potential risk of stent thrombosis is, but subsequently transition to single-agent oral anticoagulant with either rivaroxaban or dabigatran. It's important, I think, to initiate anticoagulation in community settings. As I mentioned before, I think it's very reasonable for those patients who don't have a mechanical valve, who have developed atrial fibrillation and have elevated CHA2DS2-VASc score to start an anticoagulate at that point in time. And as I say, I tend to use a novel oral anticoagulant in the first instance, organise an echocardiogram, and if need be, switch to warfarin. Another potential role for warfarin might be in those patients with reduced eGFR. It's also important to ensure mechanisms are in place to monitor and support those patients when you start anticoagulation. And for these newer agents, monitoring renal function is important as they are renally cleared, and there are eGFR cut points for when one would consider stopping that and potentially switching back to warfarin. And I'll go through that in the table a little bit later on.
Just a quick question before we move on. Someone's wondering, and I am too actually, why are women at high risk of stroke from AF? Gosh,
I don't have a good answer for that. There's not a biologically plausible mechanism for why that should be the case. Greg Lip's data from the BAFTA trial, where they used warfarin or aspirin, seemed to suggest that women were at slightly higher risk. It doesn't seem to be associated with other confounders in that randomized trial, but it hasn't been reproduced in North America, but it has fallen into the CHA2DS2-VASc score, again, largely because Greg Lip was the author of that, as well as the author of BAFTA. He thinks very strongly that it's the case. But there doesn't seem to be a good biological explanation that I have. So as I say, in guidelines, it doesn't seem to make the bar if that's the only stroke risk factor.
Good to know.
Yeah.
All right. Thank you.
Good. So as I mentioned before, these non-vitamin K oral anticoagulants are recommended over warfarin in patients with in all patients with atrial fibrillation elevated vascular risk, except for those with significant mitral stenosis or prosthetic heart valves. The main reason for that is they've been shown to be at least non-inferior and in certain situations superior to warfarin in terms of stroke risk reduction. And we know that the risk of these agents resulting in intracranial bleeding, which is a significant cause of potential morbidity and disability, is significantly lower than warfarin. And the decision to use an anticoagulant really shouldn't be influenced by whether atrial fibrillation is paroxysmal or persistent. It should be influenced by the presence of these other stroke risk factors. And considered across the wider spectrum of the patient's condition. And using a score like the CHA2DS2-VASc score is a useful way of estimating that. Renal and hepatic function should be tested before initiation of these novel oral agents, particularly given that they are renally cleared. And it's reasonable to measure these annually thereafter, or if you have clinical suspicion that there might have been a change in renal function.
Just with regards to some of these newer agents, we've got 2 new ones that have come out. Is there a reason to choose one over another, or just sort of curious about the 2 different forms?
Yeah.
And dosing as well is another question that's just come up.
Good. I'll talk about dosing in a moment,
sure.
But from my perspective, they're very similar.
Okay.
Dabigatran, as we know, we've had access to for a number of years in New Zealand. It's twice daily. We need to use it when the eGFR is more than 30.
Yes.
We shouldn't use it when it's lower than 30. A number of patients will develop GI side effects, and the clinical trials suggest that maybe 1 in 5 might develop that.
Okay, it's quite high. Yep.
Yeah. Rivaroxaban has recently become available in New Zealand. We need to understand the dose of that is 20 milligrams daily. However, if people have moderate renal impairment, so an eGFR between 30 and 50, there's a dose reduction, and that's down to 15 milligrams a day.
Okay.
One of the questions I get asked quite a lot is whether a person with higher bleeding risk should be started on a lower dose of rivaroxaban. And that's not what the clinical trials had tested the question or had answered. We really have a 20 milligram dose of rivaroxaban for those patients with normal renal function, and dose reduction is really only appropriate for those with moderate renal dysfunction. That's the eGFR between 30 and 50.
Thank you.
And these are the data that I've alluded to before, and again, pushing the point that it does not matter whether an individual patient has permanent atrial fibrillation or intermittent atrial fibrillation. What is important to understand is whether their stroke risk category is low, moderate or high. And we can understand stroke risk category based on their vascular risk profile, and scoring systems like the CHA2DS2-VASc score take into account these risk factors and are a useful way of identifying which patients are at higher risk of stroke, and therefore which patients where the would be appropriate to be treated with an anticoagulant and therefore derive benefit. And we've briefly talked on and touched on dosing of these newer agents. And as we mentioned, there are 2 doses of dabigatran available, the 150 milligram twice daily and 110 milligram twice daily dosing. And that's regardless of eGFR. So that clinical trial included those patients with an eGFR of more than 30. What we know with that is when we use a 150 milligram dose, that there is a significant reduction in stroke and systemic embolization when compared with warfarin, but no significant difference in all-cause major bleeding, but fewer intracranial bleeds as a makeup of that. Slightly more gastrointestinal bleeds as the makeup for why there's across the board no difference in major bleeding. The 110 milligram twice daily dose, when compared with warfarin, has a similar non-inferior rate of stroke and systemic embolization, but has significantly fewer major bleeding events across the board, definitely in terms of major intracranial or in terms of intracranial bleeds, but also in terms of major extracranial bleeds. In my practice, I tend to use the 110 milligram dose of 110 milligram dose of dabigatran for those patients who are at slightly higher bleeding risk. And we have scoring systems to evaluate bleeding risk, such as the HAS-BLED score. I don't personally use that in my practice.
Sure.
I tend to use other, I guess, more qualitative markers. So what do I mean by that? So older patients over 75 or 80 years of age, I'll tend to use the 110 milligram dose of dabigatran rather than the 150 milligram dose. For those who might have moderate renal impairment, I'll tend to use the 110 milligram dose. If somebody's had significant bleeding in the past, then again, you're considering risk and benefit. But if you've had significant bleeding in the past, potentially if it's life-threatening bleeding, then I'll usually not use the 150 milligram dose, and if I am going to use an anticoagulant, would use a 110 milligram dose. Again, rivaroxaban has been tested at the 20 milligram dose for those with normal renal function, and we need to understand that we reduce the dose to 15 milligrams for moderate renal impairment, so it's EGFR of 30 to 50 mils per minute. Now, there's no class effect between these two agents, so for those patients who have, say, gastrointestinal upset on one agent, it's appropriate to switch to the other, and there doesn't seem to be an effect between the two. The mechanism of action is different, and the side effect profile seems to be different as well. So if you have a patient on dabigatran who develops GI side effects, it would be reasonable to consider changing to, say, rivaroxaban. And similarly, a smaller number of patients with rivaroxaban may also develop GI side effects. And that doesn't mean that patient will definitely develop GI side effects with dabigatran. So in my practice, I would usually switch to the other. And if neither of these were suitable in terms of side effects, at that stage I would think about using warfarin. And similarly, I'd think about using warfarin for those patients with an EGFR of less than 30.
Now, just one question before we move on. We often have people that take over-the-counter medications like non-steroidals and diclofenac. In the event of utilising medications like this, what should we be recommending our patients in terms of the use of those other medicines?
Yeah, I try hard to advise patients against the use of regular non-steroidal or other agents that might also have an anticoagulant effect. And that might be at the health food store or over the counter as well. The real challenge is those patients who have, say, a sporting injury or one-off single dose. I don't see a major issue with that, providing somebody has normal renal function. Perhaps an episode of gout where you're using it for 2 or 3 days in a row might be reasonable, but I think you have to individualise that. Those patients at higher bleeding risk, the combination of non-steroidal and oral anticoagulation really is going to increase bleeding risk. I think a one-off dose probably doesn't significantly increase that risk, but more than that probably does. So I tend to advise patients to stay away from that where possible.
Fair enough, thank you.
So we have a number of questions coming through, but these are some questions that we'd brainstormed ourselves before coming through, and questions I get asked from time to time. And so, for example, a question: aspirin should be always continued with anticoagulants if a patient has cardiovascular disease. As I mentioned before, current guidelines are suggesting that if a patient has cardiovascular disease, so previous PCI work or previous CABG, that it would be appropriate to continue with monotherapy oral anticoagulation, and at a period of time after the stent has bedded in, discontinue the antiplatelet therapy. And it's typically directed by the interventional cardiologist who undertook the procedure. It might be as short as 1 month, might be as long as 3 months, might be even 6 months in certain conditions, but certainly not indefinitely. We know that the risk of bleeding with combination antiplatelet and anticoagulant therapy is important.
So that sounds like something that's quite important for us as primary healthcare practitioners to keep an eye on, particularly when someone's exiting the cardiology system, if they have had those stents, to read those discharge letters carefully to see how long we should be continuing on those.
Absolutely. And some of those guidelines have only changed in the last few months.
Right.
And so we're certainly having questions and feedback about that, because the current recommendations based on 2 trials published, one at the end of last year and one at the beginning of this year, is that aspirin is probably the agent to drop.
Right.
And so you'll be seeing some of your patients discharging from hospital, perhaps just on clopidogrel and an oral anticoagulant.
Okay.
And that's quite different to what we've done before. That's right. Yes, if you see something that looks a little bit odd, it's reasonable to double check it, but you may well be seeing that in the near future as standard practice. And that's certainly in the Auckland region. It may well come across the country.
Sure, watch this space.
Yeah, absolutely. Another question we get asked, and not infrequently, is about heparin bridging when patients are requiring either dental or other procedures.
Sure.
I think it's useful to talk with the proceduralist who's doing these procedures about that. So pacemaker procedures, which I do frequently, there's good evidence that bridging with heparin actually increases the risk of access site bleeding when compared with just continuing the novel agent or warfarin. So I no longer bridge patients with heparin. And so those patients that I think are at very low or that are acceptably low stroke risk, I'll withhold for a couple of days and then restart. But more and more frequently, I'm continuing and doing pacemaker procedures with uninterrupted agents. Dentists also quite frequently undertake procedures on patients with these medications. The Auckland DHB Dental Service are fairly comfortable undertaking procedures with uninterrupted warfarin, less so with novel agents. That might come with time and as they become more familiar with these agents. But I think it's useful, rather than immediately bridging with heparin, to liaise and consult with a proceduralist, as there's increasing evidence that bridging with heparin and the changing from one to another does tend to result in an increase in bleeding risk. Another question we get asked is also the renal impairment question, which we've spoken about. That
popped up. Yes, so please.
Good. So the question I put on my screen is, my patient is renally impaired, so they cannot have an oral anticoagulant. So we know that from the clinical trials that dabigatran and rivaroxaban can be appropriately used down to an EGFR of 30. Below that, clinical trials would suggest that we should use warfarin. There is a lower dose of dabigatran available, 75 milligrams. That's been licensed by the FDA in the US for use with EGFRs of between 15 and 30. That's not been my personal practice to do that. I get concerned about a medication that is renally cleared, and in that range, I think some of these patients might develop further renal dysfunction fairly quickly, and unless you're monitoring things very closely, I think it's hard to take on that practice. Now, the trial data that led to that recommendation wasn't based on clinical evidence, it was based on pharmacokinetic information obtained. So we don't have good clinical data to that, but they do recommend it in that situation. So as I say, if the EGFR is less than 30, I personally tend to use warfarin.
Sure.
Also, one or two questions there.
Why don't we just use the 110 milligram dose of Pradaxa? Sorry, I'm more familiar with the brand name.
Okay.
For all patients if non-inferior to warfarin, just probably referencing the previous study that we brought up.
I certainly know practitioners who adopt that practice, and it's a reasonable practice. As I mentioned before, it is non-inferior to warfarin. People have, in terms of stroke and systemic embolization, and it's safer than warfarin from a bleeding perspective. And this is where as I mentioned before, I consider bleeding risk when I consider dosing of dabigatran. For those patients at lower bleeding risk, now have a better stroke risk reduction by the higher dose. I think those patients at low bleeding risk, it's reasonable, and as I say, in my practice, I tend to afford and like the idea of trying to reduce risk of stroke as much as possible. But I do know people that use the 110 milligram dose universally for that rationale. But I like the idea of being able to reduce stroke by as much as I possibly can, and using that dose achieves that.
Great, thank you.
So if we step on to a case study to try and illustrate and talk through a few more aspects of atrial fibrillation care. This is a 46-year-old man with a 12-month history of both heart failure and atrial fibrillation. He has NYHA class 2 symptoms, meaning that he is breathless when he does more strenuous activity than would be considered day-to-day. So he can either walk about his house, he can do housework, chores in the yard, and not get particularly breathless, but when he exerts himself to undertake exercise, he becomes breathless. He's diagnosed with a non-ischemic dilated cardiomyopathy, so normal coronary arteries. At that same time, he was noted to be in atrial fibrillation. Now, the duration of that was uncertain. This coincided with the presence of breathlessness. He's overweight at 120 kilograms. At this stage, his blood pressure is adequate, 120/74, and his ventricular rate relating to his atrial fibrillation is faster than ideal, 110 beats per minute. Ideally, we would try and target somebody in heart failure to have ventricular rates at rest of ideally less than 80 or 90. If it can be achieved without side effects, ideally less than 80. He's euvolemic with no current evidence of heart failure, and his medical therapy is pretty reasonable at this point in time. He's been up titrated to 5 milligrams a day of bisoprolol, the maximum dose being 10 milligrams a day, to cilazapril 2.5 milligrams a day, the maximum dose being 5. And he's requiring a fairly minimal amount of furosemide to maintain euvolemia. So when we undertake investigations, he has an elevated NT-proBNP. This is a prognostic importance in managing those patients with heart failure, and in a number of regions around the country is used as part of risk stratification or prioritisation for echocardiography. We know that in a number of regions around New Zealand that echocardiography at base hospitals is a precious resource, and wait times can be as long as 9 or 12 months in some parts. And so NT-proBNP is being used by some DHBs as a way of stratifying and trying to prioritise what is a scarce resource. He did go on to have an echo, and this shows all 4 of his cardiac chambers are dilated, and he has severe impairment of LV systolic function. His thyroid and renal function is normal, his hemoglobin is normal. We already knew that his heart rate was suboptimally controlled, but he went ahead and had a Holter monitor and showed that overnight he's not having any significant pauses. Some patients who are overweight, who might also have sleep apnea, overnight will have significant pauses, and if we increase beta blocker dose, then we might actually, for some of these patients, make them excessively bradycardic. So when we're considering management of a patient with atrial fibrillation, we're considering the acute and chronic components nearly simultaneously when we consider aims. It's important to consider cardioversion for those patients who are unstable, and this is typically in those patients in the emergency department, more so than those in primary care. So those people with symptoms, say chest pain or syncope, particularly those who are hypotensive, we would consider an upfront cardioversion. We anticoagulate patients to reduce stroke risk according to stroke risk stratification, and that's something that we would do upfront depending on what their stroke risk category is. It's important to control their ventricular rate. For those patients in heart failure with decompensation, my usual first aim is to try and obtain euvolemia before pushing heart rate control excessively. This is probably one group of patients where beta blockers might cause some harm from a negative inotropic effect, those patients with decompensated heart failure. I think it's useful to try and compensate patients, get them euvolemic, get them peripherally warm before pushing beta blocker dose and to obtain rate control. It's useful to inhibit the renin-angiotensin-aldosterone system, and we use guideline-directed therapy, including ACE inhibitors in the first instance, and if that's either not tolerated or associated with cough, we can switch to angiotensin receptor blockers such as candesartan or losartan. For those patients who are still symptomatic with their atrial fibrillation, then considering rhythm control at this point in time is a reasonable thing to do. And we might obtain rhythm control by cardioversion. For a small group of patients, their left ventricular dysfunction could be in fact due to the atrial fibrillation, and by treating the atrial fibrillation, restoring and ideally maintaining sinus rhythm might for some patients improve their LV function. And for those patients, strategies that try and maintain sinus rhythm long term should be considered. It's also important to evaluate and treat other cardiovascular disease where present, particularly ischemia, hypertension, diabetes. And so when considering treatment goals and desired effects, hemodynamic stability should be the first goal, particularly in the emergency department for unwell patients. We then consider cardiovascular risk reduction, stroke prevention, and then it's at that stage that we shift focus from these more acute goals where we're aiming to improve life expectancy towards those goals that aim to improve quality of life, left ventricular function, and social functioning. So for our patient, we've elected to take a rate control strategy, and there are several medications and strategies that we can use to achieve this. These are data published last year from the National Heart Foundation of Australia and New Zealand in conjunction with the Cardiac Society. The first point of call for decision making here is whether your patient has left ventricular systolic dysfunction. And a little bit like anticoagulation, we can be guided by history before we have echocardiography to guide us further. Our patient that we talked about before, he had an elevated NT-proBNP and was breathless. So it's reasonable to assume that he probably had left ventricular systolic dysfunction, and so therefore beta blockers would be our first line therapy. For those patients who don't have symptoms of heart failure, normal physical examination, and say a normal NT-proBNP, it would be reasonable to consider either a beta blocker or a non-dihydropyridine calcium channel blocker, such as diltiazem, to obtain rate control. I tend to use diltiazem for those patients with airways disease in the first instance, but across the board, I tend to favour beta blockers. They tend to obtain rate control a little bit easier with lower doses and tend to be less associated with symptoms like postural hypotension or other unwanted symptoms like leg swelling. Digoxin still has a role in the management of atrial fibrillation. It's gotten a bad rap and bad press in the last few years. It's important to monitor the serum digoxin level. When the DIG trial has been recently evaluated, looking at digoxin levels, it's clear that those patients who had sudden death on digoxin had digoxin levels above 1.2. Most laboratories will quote the upper limit of digoxin level to be 1.8. So it suggests that the reference range, what we should target patients to, should be downshifted. I don't tend to use digoxin as first-line therapy, but we use it as second-line therapy. It's important to monitor the serum level, tend to monitor that as a trough level, and I start low and will step up if need be. And again, aiming digoxin levels less than 1.2. Now, some patients, particularly those in the acute setting, say in the emergency department with hemodynamic instability, you might be wanting to obtain initial rate control to just take the head off things while you're managing their LV dysfunctional heart failure. In that setting, amiodarone can be quite a useful rate control agent, not as a long-term strategy, but as a bridge to managing the rest of the patient's care. So that might be managing their acute ischemia, might be managing their heart failure. In that instance, amiodarone can be used for a period of days or weeks to achieve that, and then transition back to a beta blocker, potentially in combination with digoxin. For those patients where we can't obtain adequate rate control with medical therapy, or where beta blockers and calcium channel blockers are contraindicated or not well tolerated, then a fallback option might be to consider a permanent pacemaker, which, as you know, reduces the chance of bradycardia, but then to subsequently destroy the AV node with catheter ablation. That then creates complete heart block, and the patient then paces all of the time, and is a permanent, irreversible solution, but obtains rate control. Really reserved for those patients where we're unable to obtain good rate control with pharmacological therapy, despite trying fairly hard. Again, it's an irreversible therapy.
Before we move on to the next slide, just a few questions around the beta blockers and diltiazem. Now, metoprolol used to be the medication of choice. How does it stand now in the advent of other available beta blockers? That's probably the first question. And the second question is, what are your thoughts about the utilising combinations of medications such as the calcium antagonist, non-DHP calcium antagonist and the beta blockers?
Yeah. So in my practice, I tend to use metoprolol or bisoprolol as rate control agents. They're also proven to be effective in the management of patients with heart failure, which is a common conjoint diagnosis. Carvedilol is a useful beta blocker for heart failure, but doesn't tend to be quite as potent at heart rate slowing and atrial fibrillation. So for that reason, I tend to use metoprolol or bisoprolol. Probably a 50-50 mix in my practice. I tend to find bisoprolol easier to titrate.
Sure.
I think patients tend to get less hypotensive symptoms from it. That's anecdotal. It's not a clinical trial-based thing, but I think it's a little bit easier to titrate. And in terms of combination therapies, my personal approach is to try one agent and to up-titrate to get effect, and then to back off if there's side effects. I certainly have colleagues who will use lower doses, say metoprolol CR at 47.5 or 95, and instead of titrating that up further, we'll add in a lower dose of, say, diltiazem, with the idea that bigger doses tend to be associated with a higher rate of side effects, and lower doses in combination can often achieve adequate rate control. I don't think there's a perfect one-size-fits-all to that, but for certain patients, when you push doses up, they will get dose-dependent side effects, and so maybe lower doses in combination can be appropriate for some patients.
And one person has brought in a question about the use of, just let me find it, rate control, presenting an elderly patient. This is a very common presentation in primary healthcare, which I thought I would bring up just at this timely point. So presented for the first time, they're asymptomatic AF, fast at times. They have clinical heart failure. The blood pressure is good. Can we use a beta blocker for rate control given the new onset of failure in this elderly person?
Yeah. So if somebody's asymptomatic and they're hemodynamically well, there's no rush.
Okay.
So I would, for a patient like this, I would tend to treat with some diuretic, evaluate the remainder of their renal function, their thyroid function, etc. Reassess in a week or two, making sure that their renal function hasn't deteriorated with diuretic therapy, and then once the euvolemic, institute a beta blocker.
Okay.
And I tend to use a beta blocker in that situation.
Thank you.
So cardioversion is a useful strategy for restoring sinus rhythm in those patients with relatively recent onset atrial fibrillation. For those patients with hemodynamic instability, this is typically undertaken in the emergency departments and is a very useful strategy at restoring sinus rhythm. For those patients who are not hemodynamically unstable, we're often seeing them either in our clinic rooms or in your practice. And at that stage, it's really a patient choice, and it's elective about whether one uses electrical or a pharmacological approach. My personal approach to this, and I think a lot of cardiologists, is to favour an electrical cardioversion in the presence of some sort of antiarrhythmic medical therapy, with the intention of using that to try and maintain sinus rhythm after a cardioversion. And decision-making about antiarrhythmic therapy depends largely on the patient's comorbidities. So for those patients with coronary artery disease or left ventricular dysfunction, the likes of flecainide would be considered contraindicated. And one would use amiodarone commonly in that situation, particularly in New Zealand. For those patients who have no comorbidities, no symptoms of ischemia, no evidence of heart failure, normal echo, and for these patients, if they're well, we have the time to wait for an echo before undertaking cardioversion and starting medical therapy. I tend to use flecainide. It's my preferred antiarrhythmic in this setting. Sotalol would be another option. Often patients with sotalol, to achieve doses that are electrically effective, one needs 80 or 120 milligrams twice a day. Often that's making patients bradycardic or developing symptoms of orthostatic hypotension. And so once we've undertaken cardioversion, I might just go back one slide.
Sure.
A question that had come through beforehand was about anticoagulation after cardioversion. Now, for elective cardioversion, regardless of the CHADS-VAS score, we would anticoagulate a patient for at least 3 to 4 weeks prior and at least 4 weeks afterwards to reduce the risk of pericardioversion, stroke and systemic embolization. For those patients with a CHADS-VAS score of 0 who come into the emergency department with, say, a very short episode of atrial fibrillation, there's less good data, and guidelines would suggest it's reasonable to anticoagulate those patients for a period of time afterwards. My personal practice is to anticoagulate those patients for 4 weeks afterwards. Again, there's not a randomized trial about duration, and guidelines suggest it's reasonable too. I fall on the side of doing so, partly because I've seen 2 patients have stroke a week or so after cardioversion in this situation who had CHADS-VAS scores of 0. So that's my personal practice. Clearly, if somebody had a very high bleeding risk, I would take that into account with that consideration. So we've cardioverted a patient back to sinus rhythm, and we've decided that we're going to try and maintain sinus rhythm as a strategy in the medium to long term. Decision making for that initially is about antiarrhythmic medical therapy. And as I alluded to before, decision making there depends on the presence or absence of structural heart disease.
Mm-hmm.
For those patients with left ventricular systolic dysfunction that's more than mild, significant left ventricular hypertrophy, or coronary artery disease, I tend to use amiodarone. For those patients who don't have any of that, normal hearts, no coronary disease, I tend to use flecainide in the first instance. Now, catheter ablation is becoming a much more commonly used treatment and is available in all of the major cardiac surgical centres around New Zealand. So that's Christchurch, Wellington, Waikato and Auckland. And we tend to use this as a treatment strategy for those patients who have trialled an antiarrhythmic and have either developed significant side effects relating to that, not tolerated it, or have had breakthrough arrhythmia despite that, i.e. the medication is not effective. We tend to use that strategy for patients with paroxysmal atrial fibrillation more so than those with persistent atrial fibrillation. Those with more persistent atrial fibrillation, we may try 2 medications before going to a catheter ablation.
With the amiodarone, it's a medication which can potentially have significant side effects. So with regards to us in primary care, if we have to receive patients that have been put on amiodarone, are there any tips with regards to things that we should be looking for in terms of potential side effects and investigations and monitoring?
Yeah, great. Good question. And a question we get a lot. So I'll start that by saying it's been great weather around the country in the last few days. And one of the first things I tell patients, particularly this time of year, is amiodarone, you need to be sun smart. Patients will have an increased risk of sunburn and skin discoloration on amiodarone. And even patients with darker complexion, say from the subcontinent, Maori and Pacific patients as well. So hats, sunscreen, etc. In terms of more specific monitoring, thyroid and liver function tests are recommendations. I tend to monitor them every 3 to 6 months. If a patient's been on amiodarone for more than a year or two, I'll monitor it more frequently, so it's 3 months. Initially, if I'm starting a patient on amiodarone for, say, 3 or 6 months, say after a cardioversion, and I'm planning for short duration therapy, I might only monitor it initially and then at discontinuation. One of the things that we don't talk about so much with monitoring is the ECG. Amiodarone prolongs the QT interval and can cause proarrhythmia. Corrected QT intervals of more than 500 milliseconds are associated with an increased risk of proarrhythmia and would be a reason to be circumspect and ask the question about whether you should be continuing or stopping that agent. MedSafe on their data sheets recommend annual ophthalmology assessment, annual chest x-ray and annual pulmonary function testing. I know there's a lot of regions around the country that have challenges with access to ophthalmology, and those are 3 tests that I don't personally routinely recommend. The basis for those recommendations, in my opinion, is a little bit nebulous. Ophthalmologists and optometrists will see deposition in the retina for those patients on amiodarone. It is really sight-threatening. And we all have fear of amiodarone-mediated pulmonary fibrosis as a potential risk. Unfortunately, by the time there's evidence of that on a chest x-ray or pulmonary function testing, the damage is already done. And because of the half-life of amiodarone being weeks and weeks, if you stop the agent, there'll still be significant amiodarone present even a short number of months later. So I don't personally do that as routine testing. My personal practice is to try not to use very much amiodarone unless I really have to, and tend to try and use amiodarone for defined short periods of time. So I think if you have patients on amiodarone, that's probably the most important aspect of their care, is to consider, do they still really need it? If a patient goes into atrial fibrillation and they're asymptomatic with good rate control, maybe you should switch strategy from rhythm control to rate control and stop the amiodarone. And I think that's probably the most important message with amiodarone, is review whether it's still needed. So I mentioned catheter ablation before, and there are several technologies available for achieving it in terms of treating atrial fibrillation. These are the 2 technologies that are used in all hospitals in New Zealand that undertake this treatment. And there are pros and cons of each, and rather than getting into specifics, I'll mention that the target for this treatment is to try and electrically isolate the pulmonary veins. It tends to be where the pulmonary veins weave with the left atrium, the ectopic beats arise, exit the left atrium, and then have collisions with the sinus beat or other ectopics that then trigger atrial fibrillation. And by electrically isolating the pulmonary veins, we're able to eliminate atrial fibrillation in approximately 70 or 80% of patients with paroxysmal AF, and approximately 50% of those with more persistent forms. There are a number of patient-specific factors that go into this. Those patients with very large left atrial sizes, we're less likely to achieve success because of the presence of scar tissue, fibrosis and the like in the chamber. Those people with other uncorrected severe metabolic disorders such as morbid obesity, uncontrolled diabetes, all of that creates a milieu within the myocardial tissue that promotes atrial fibrillation, and one would really want to control those factors before going on to considering an AF ablation. So when we consider these factors, rather than just considering it in the context of AF ablation, it's really about how do we try and manage the overall patient who has atrial fibrillation. This is data from Adelaide, and they have a nurse-led clinic that allows not only patients to see their nurses, but their nurses to be facilitated to go into the community and see patients in their homes. These are the targets that they use in their aggressive risk factor management, and it highlights the importance of not just looking at atrial fibrillation, but the context in which the patient has their atrial fibrillation. And by targeting these factors, we can reduce the frequency of patients' frequency of paroxysms of atrial fibrillation by about a third, which is nearly as good as most medical therapies. And so in conjunction with medical therapy or catheter ablation, risk factor management and targeting these factors is a really important adjunct. So for our patient that we talked about before, we've optimized the rate control, and because he has severe left ventricular dysfunction, we're avoiding diltiazem. We're using beta blockers, bisoprolol in this case, and if not tolerated or we can't achieve it with a beta blocker, we'd add in digoxin at that stage, being careful to monitor the digoxin level. We've increased his ACE inhibitor. Because of his obesity and because of some daytime somnolence, we've referred him for a sleep study. We know that the presence of sleep apnea in patients with heart failure and atrial fibrillation is high, and that CPAP is a useful adjunct to improve quality of life, reduce daytime somnolence, get people up and moving and lose weight. It becomes a virtuous circle. We referred him to a dietitian to help with managing his weight, and that's a service that is fortunately available to us in Auckland and might not be available in every region around the country. And we're repeating his Holter monitor again to make sure that we've adequately rate controlled him and that we've not created, say, overnight pauses. So when we're thinking about improving the quality of care with patients with atrial fibrillation, we're aiming to increase the frequency of pulse checks, opportunistic case finding, particularly in those older patients, so 65 years and older. And we're doing that to identify those patients with atrial fibrillation who might be at risk for stroke. And then we're targeting those patients with anticoagulation to reduce their risk of stroke. And we're also targeting the discontinuation of aspirin as atrial fibrillation stroke risk reduction is best achieved with novel oral anticoagulants rather than aspirin. And we're using warfarin only in a small group of patients. We're adopting an evidence-based approach to stroke prevention, using the CHADS-VAS score to risk stratify those patients at higher risk, and using novel agents to minimise stroke risk. We're endorsing stroke risk prophylaxis regardless of whether the patient is in atrial fibrillation at the time that you see them or whether it's permanent paroxysmal. And we're promoting the discussion between prescribers and individuals about choices of anticoagulation and also choices of rate and rhythm control. And as I mentioned before, we've got a number of rhythm control options available, which include medical therapies, antiarrhythmics, and potentially catheter ablation for appropriate people. I'd like to end there with promotion for Atrial Fibrillation Awareness Week, which is in conjunction with the Heart Foundation, which is running in a fortnight from the 18th to the 24th of November. As we're publicly trying to increase the awareness of atrial fibrillation by the use of pulse checks and self-monitoring, so trying to empower our patients to evaluate themselves. And participating general practices can go into the draw to win one of these alive calls that I showed you earlier, which might be a way of monitoring either patients in your practice when they come in as part of pulse checks that your practice nurses can be involved with. Thank you very much.
Great. Before we wrap up, we'll just go through a few questions, if you don't mind, that have been brought up by our audience. So the first question that I have here, it's on digoxin, and it's just really a question about monitoring, how frequently we should be monitoring individuals that do actually need it.
Yeah. So the monitoring that I would do is threefold. One is renal function, the second is digoxin levels, and the third is ECG. In terms of renal function and digoxin levels, I tend to monitor that every 3 to 6 months. And if somebody has mild or moderate renal dysfunction, that would be every 3 months. If people have completely normal renal function, maybe every 6 months. And ECGs, I'm looking at, digoxin doesn't routinely prolong the QT interval, but we have this ST segment change at the back end of the QRS complex that's best seen in leads V5 and V6. Now, if that becomes very pronounced, that does suggest that patients are more prone to these delayed after depolarization effects on the cardiac action potential and proarrhythmia, which is probably the mechanism for death. So that's clearly what we're trying to avoid. So an ECG is a useful adjunct in addition to blood test monitoring.
Okay, great. Now, there's just a question with regards to the reversal agents of these novel anticoagulants. Would you be able to sort of speak on that with regards to, I think there is one for one of them, but I'm not quite sure for the other one. So where do we sit on that at the moment?
Correct. So dabigatran has a reversal agent named idarosuzumab, which is a great tongue twister, aka Praxbind.
Yes.
And Praxbind idarosuzumab is available in every blood bank of every major hospital in New Zealand. My understanding is that it's used approximately twice a day in New Zealand somewhere. And approximately 2/3 of the time it's used is for those patients requiring emergent surgery. So that would be, say in my department, that might be a patient who presents with an aortic dissection, who needs emergency surgery. And about 1/3 of patients who require this are being treated because of hemorrhage, because of bleeding issues. It costs about $3,700, so it's not cheap. It's not something we use lightly, but it's really very effective. From the time that you administer it, anticoagulation as measured by DTT, direct thrombin time, reverses within 5 to 10 minutes. So it's very quick and very prompt, even more prompt than warfarin. And it can be dosed regardless of renal function. Now, we have that available for dabigatran. Now, there isn't a commercially available reversal agent for rivaroxaban. There is an agent that's currently undergoing clinical trials, not in New Zealand. One such trial has been published about 2 years ago, and the FDA in America has asked for a second trial to evaluate that in some more detail. It seems likely that will become available if the trial is positive at some point in the next few years, but it's not currently available. At this point in time, major bleeding with the use in patients with rivaroxaban is treated with supportive care, and most health boards will have a protocol or policy for how to manage these patients. I know we do at Auckland. It's certainly something that our cardiac anaesthetists for our dissection patients on my department are very interested in.
Okay, great. I think you might have mentioned this next or comment or question on the very last slide with your take-home messages, but someone's just seeking clarification on atrial flutter with regards to, is it the same risk, same medications that we use?
So atrial flutter and atrial fibrillation are, I consider them cousin rhythms, the atrial arrhythmias. So atrial flutter is a macro-reentrant short-circuit spinning loop rhythm in the right atrium. Typical form of atrial flutter, and atrial fibrillation involves both atria, but it's triggered from the left atrium. Stroke risk is similar regardless of whether the patient has fibrillation or flutter, both of which increase risk of stroke, and we should use the CHADS-VAS score to decide who should be treated with oral anticoagulation. Now, rate and rhythm control with atrial flutter is a little bit different than with atrial fibrillation, and that's mainly because medical therapies don't work very well for treating atrial flutter. So our treatments for atrial flutter in terms of rate control often doesn't work very well. Often we still have patients with tachycardia. And rhythm control medical therapies are less effective than with atrial fibrillation. So our usual approach, at least my usual approach, is to think about catheter ablation. And I have a lower threshold for catheter ablation with atrial flutter. Our ability to treat atrial flutter with catheter ablation is about 95%, and the likelihood of recurrence is very small. So our ability to treat that rhythm with a catheter ablation is much higher, and it's a slightly safer procedure as well. So I have a higher regard for catheter ablation, and will use that more frequently as an upfront treatment modality for atrial flutter than for atrial fibrillation. But from a stroke risk perspective, we should consider them very similar.
Okay, that's really good to know. Thank you for clarifying that. Now, just a question around medications that we use commonly in primary care and potential interactions with these novel agents, these anticoagulants. Is there any interaction with SSRIs, so that's our selective serotonin reuptake inhibitors, and steroids in the long-term and bleeding risk with anticoagulant?
Yeah.
To your knowledge?
To my knowledge, so for SSRIs, I'm not aware of a specific drug-drug interaction between those two. Now, steroids, a little bit like non-steroidals that we spoke about before, do have an increased risk for gastrointestinal bleeding as a consequence of peptic ulcer disease. So I would be cautious about using anticoagulation in patients on long-term steroids. And when I say cautious, it's about evaluating risk and trying to mitigate that risk. So obviously steroids have important potential side effects, so we want to use the lowest dose that's suitable for the patient. I would, if I'm going to use a steroid and an anticoagulant together, I'll commonly use a proton pump inhibitor or some other method to try and reduce GI bleed risk. I don't have a perfect evidence base for that, but it seems reasonable to me.
Okay. Now, I think you actually touched on this before, but just wondering if you could explain the etiology behind the metabolic diseases and the increasing AF prevalence.
Yes, so that's a really good question. Hypertension is probably the best example of this. So hypertension results in an increase in left ventricular pressure because you have to generate pressure against the arteries. And the atrium sit on top of the ventricles. Now, the atria are very thin-walled and very prone to pressure stress, and their response to that is to stretch and then to develop fibrosis. And so with hypertension, a mechanistic link is relatively straightforward. Now, with some of these other metabolic conditions, so dyslipidemia, sleep apnea, diabetes, hyperuricemia, all of these create an increase in circulating cytokines, inflammatory markers. All of those are associated with the promotion of myocardial fibrosis, scar tissue, and the like. And that is felt to be the mechanistic reason for where and why atrial fibrillation is more common. Similarly with obesity.
Okay. And, oh gosh, there's so many questions here. Someone's wanting to know the effect of alcohol on atrial fibrillation.
Yes.
Does that run along the same themes?
It does seem to run along the same themes. And so alcohol can be considered probably in two different ways. One is for those patients with paroxysmal atrial fibrillation, binge drinking and the day after, so to speak, are times when atrial fibrillation can be precipitated by alcohol. We also know that long-standing chronic moderate or more alcohol is associated with the development of atrial fibrillation, probably due to the mechanism of direct cardiotoxicity. The group in Melbourne have recently presented data suggesting that if you can reduce your alcohol intake from moderate to less than moderate, so that would be 1 to 2 drinks of alcohol, units of alcohol, 3 to 4 times per week, that you can reduce your episodes of paroxysms of atrial fibrillation by maybe 20 to 40%.
Okay, thank you. I think that's probably all we have time for today, so thank you very much for coming in and going through a topic which is sometimes quite challenging for us in primary care to manage, but it's really nice to produce some key points for us to take through to our practice, which we can use literally next Monday. Now, just to wrap it up, I'd just like to emphasise and thank again that for coming in tonight, and just to let you all know that a copy of this webinar will be available on our website in about a day or so, and our next webinar will be on the 19th of November, I believe, and that'll be on perinatal anxiety and depression disorders. So I hope to see you there. So thank you again, everyone, for joining us tonight, and good night.
Thank you.